Welcome everybody. My name is Martin Holt from the Centre for Social Research in Health. Thanks for joining us for this update on HIV and stigma. First, I'd like to acknowledge that if you're participating today in Australia, you're on unceded Aboriginal land. I'm taking part today from Gadigal country, and I'd like to pay my respects to elders past and present and extend that welcome to any First Nations people who have joined us today. So as I mentioned, this is an update on the Centre for Social Research in Health's annual report in Trends in Behaviour. There was a previous session last week. We're doing a sequence just outlining some of the findings. Let me just check that I can move forward. This is part of our federally funded surveillance work that we do for the Australian government, compiling a snapshot of research and trends each year. This year's report, which will be out soon, and we will send it to all of you if you registered for this session, will be launched soon. But we thought we'd start discussing some of the findings in public to draw some attention to some current issues in the field. The report, we've done kind of separate reports on different topics over the last few years, but this year it will be one compendium report covering viral hepatitis, harm reduction, HIV and STIs, and stigma. And Tim and I, as I mentioned, my co-presenter Timothy Broady, will be talking today about a selection, just some of the results related to HIV, sexual health and stigma. But I'll note that the report has a broader range of topics included in it, including commentaries and reviews of peer-reviewed research related to blood-borne viruses and the populations we work with. I'd like to acknowledge my co-authors who are listed there: Tim, Eleanor, Jake, Lise, Lauren, Carla, and Lamin. Lamin sends her apologies, she can't be here today. I believe Carla and Lise are with us, and Tim you'll hear from shortly. I'd like to acknowledge that this work is funded by the Australian Government Department of Health, but almost everything we're presenting here today is done in collaboration with state governments and community organisations who we rely upon to undertake most of our research. And the participation of affected communities is a key feature of much of the work we do. So I'll just give you a brief outline of what we're going to do. Firstly, I'm going to talk a bit about some of the HIV trend data related to gay and bisexual men from the Gay Community Periodic Surveys. This isn't the only thing in the report on related to HIV, but it shows you some long-term trends, hence the title of the report. I'll mention some spotlight sections, some more recent areas of work, and then I'll pass over to Tim, who will talk about the Stigma Indicators Monitoring Project. We're hoping that there will be time for Q&A at the end, but if you feel shy, please feel free to put questions in the chat and we'll pick them up as we go along or at the end. But at the end, yes, you can also put your hand up and ask a question, and we can make it a little bit more interactive. So without further ado, I will move into the periodic survey section. Okay, so a reminder, many of you will be familiar with what these are. The Gay Community Periodic Surveys are a behavioural surveillance system of gay and bisexual men that have been conducted since 1996 and now take place in 7 states and territories. If anyone is online from the Northern Territory and would like to join, please let me know. The questionnaires are specifically related to HIV and sexual health. They're sexually explicit. You can see our glamorous ACON colleagues here offering questionnaires to people at a Mardi Gras event. Participants fill in the questionnaire themselves and don't need to leave any contact information, so they can be completed anonymously. Historically, the surveys have been very reliant on recruitment at LGBTQ venues and events. But for the last 10 years, we've also used online advertising as well, and that was critical during COVID-19 to sustain recruitment. And you'll see in a bit how COVID-19 and some of the changes to recruitment affected some of the trends. Okay, so I'll just make a note, just a brief description of some of the characteristics of the sample, and also noting some of the change in the last few years as we adapted to COVID-19. The majority of the sample shown here in yellow, the yellow line, historically have been gay identified men, but that has declined a bit in the last few years, and that actually started a little bit before COVID-19, where we're recruiting more bi plus and other queer and other identified participants. So now just under 80% of the sample is gay identified. The big change you can see there in blue is the proportion of the sample recruited online. So way back when the majority of the sample was all recruited face-to-face, and then we introduced online recruitment in 2014, and you can see we were very reliant on online advertising and recruitment and participation in 2021, when we had a number of restrictions imposed by COVID-19, and it wasn't really safe or possible to do face-to-face recruitment. So we're very appreciative of our community partners in particular who helped us pivot the surveys online. You can see, despite that change, some of the other characteristics, and I've put two key ones here related to discussions of the HIV epidemic in Australia. The proportion of overseas born participants has been fairly stable over time at around 30%, and that has not changed much. And the very important subgroup in the sample are participants living with HIV, and you can see that historically that has varied between around 7 and 10%, and there's been a bit of a dip recently, but I'm hoping we can re-engage our HIV positive peers from this year going forwards. Okay, so this one very busy slide I've included just to point out that in the report we report the indicators from the periodic surveys related to gay and bisexual men. We report where we can by every participating jurisdiction, and then kind of give a national average or a national trend line as well. And I'm only doing this on one slide because it's too chaotic on the ones that follow, and the rest of the slides that I'm going to show you are largely discussing the national picture. So this is an indicator we look at. One of the markers of sexual behaviour or sexual activity is participants who report more than 10 male partners in the last 6 months. Now, the reason we do this is people who are more sexually active historically tend to report more risks for HIV and STIs, and we're particularly keen on engaging this group in services like testing, prevention, and treatment services. You can see historically, so I'll just note the state territory variation. You can see there's quite a bit of variation between the jurisdictions. There are fewer participants in Tasmania, for example, who report a high number of male partners. And the lines towards the top are in some of the bigger eastern seaboard states, where there may be more opportunity and larger communities, and people go out and play more often. But the key one I want to note here is the national line. So that's the national average of all the participating states and territories. You can see historically it's been reasonably stable, with around a fifth of the sample reporting more than 10 male partners in the last 6 months. And something really obvious has happened in the COVID-19 period, where the proportion of the sample reporting a high number of partners dropped quite a lot, and it has not actually, last year had not actually recovered. It had remained about 5% lower than in the past. And so I just wanted to put that up front, that we can still see some changes in the sample related to the COVID-19 pandemic. Okay, so on that note, I'm going to turn to the participants living with HIV. You may remember this is up to 10% of the sample. Gay and bisexual men remain the population group most affected by HIV in Australia. Obviously, Australia has signed up to very ambitious global targets, which now focus on diagnosing 95% of people living with HIV, ensuring 95% of those people are on treatment, and 95% achieve an undetectable viral load, viral suppression through HIV treatment, because this is good for their well-being, and it also means that they can't pass on HIV to their sexual partners. You can see here there's a very good news story, but we're tantalizingly close to 95, the second two I mentioned. Historically, 10 years ago, you can see that just less than 90% of participants living with HIV in the sample were on treatment. But from 2015 onwards, it's been consistently over 90, and in a few years, we've hit 95 as well. And we keep sort of bobbing around quite close to that treatment level. The periodic surveys sometimes diverges slightly from clinic-based samples on estimates of HIV treatment coverage. Because we go out into the community, we're more likely to get people who may not be consistently engaged with services. But you can see here the levels of treatment are very high. And what we also can see is that once participants living with HIV are on treatment, nearly all of them achieve an undetectable viral load. So that appears to be more consistently near the 95% level. And my interpretation of this is, while it varies by a few percentage points, there hasn't really been any change during the COVID-19 period. So treatment does not appear to have been negatively affected during COVID-19. That said, we do see some other changes in HIV care. So in the past, most people living with HIV would have had a number of appointments per year to monitor their HIV. And the recommendation now is for fewer appointments. And during COVID-19, many services, particularly for people who are stable on treatment, said, you know, it's risky coming into a health service, we'll try and do appointments remotely and so on. And so you can actually see a very big change here away from participants having 3 or more appointments per year for their HIV care, towards the majority of participants living with HIV having only 1 or 2 visits. And we think this is in line with best practice at the moment. I've never particularly looked at this indicator before, but I think it's actually quite interesting and to note the 6 to 8% of the sample who say they have not attended HIV care in the last year. And that to me actually seems quite high. So I think that is an area, I think it's interesting that in the periodic surveys, we do actually find people who don't appear to be on treatment and don't appear to be regularly attending care, even at the very small numbers. I think that's something we might go away and look at in a bit more detail. Okay, so now I'm going to turn to the rest of the sample. So these and some of the other broader indicators. So HIV testing is obviously a key gateway for access to HIV services, prevention and care if diagnosed. You can see here the majority of the gay and bisexual men who take part in the surveys have at least had 1 HIV test in their lives. That's the line in blue. It's historically hovered around the 90% mark, maybe a little bit lower at the moment, where we've, as we've broadened recruitment using online methods, that we're getting more people who have not yet had an HIV test. You can see a COVID effect here. So testing in the last year in orange fell quite noticeably during the COVID affected period and has not returned to pre-COVID levels. I think there's quite a bit of discussion in the sector about what we can do to actually make encourage people to re-engage with testing, particularly if they're sexually active. And the lower line is higher frequency testing. So amongst those who presented for testing, those who've come back for repeat tests in the year, many of you will be aware this is most likely among PrEP users. When they come back for a prescription, they're often tested for HIV and STIs. So you can see that high frequency testing historically over the last 10 years has increased, fell during COVID, and it appears to be recovering a little bit. And that's probably coincident with people going back on PrEP and going back to the doctor for prescriptions. Okay, so I'm coming into my last couple of slides before I pass on to Tim. This is quite a busy slide, so I'll try and explain it as carefully as I can. A key focus for us when engaging gay and bisexual men and assessing how well protected they are from HIV or what they're doing to prevent HIV transmission is we focus particularly on sex with casual partners. The number of studies in Australia that suggest casual sex is more of a context of risk historically for HIV transmission than sex with regular relationship partners in particular. So we've developed this way of categorizing the casual sex that participants have. Not everybody in the sample has casual sex, but around 2/3 of the sample usually reports some casual sex. And this is an attempt to classify the type of sex they're having and the prevention methods they're using as well. So at the bottom of the slide, you can see participants who've had casual sex but didn't have anal intercourse in dark blue. In green are participants who've had casual sex and report consistent condom use if they have anal sex. In light blue are HIV positive participants who have an undetectable viral load and don't report report condomless sex, but noting that if they have an undetectable viral load, they pose no risk of onward transmission to their partners, given our knowledge of U equals U. In yellow are HIV negative participants who are on PrEP and also report condomless sex. There's a very, very tiny group there. It's almost non-existent of positive participants who say they're not on treatment or they have a detectable viral load and they report condomless sex, very, very small numbers. And then a bigger group in red who tend to be our focus for HIV prevention efforts. Negative and untested men, they're not on PrEP, but they do report condomless sex. So they're at potential risk of HIV acquisition. So what's happened over time? There's some obvious changes here that you can see. Consistent condom use has declined over time, coincident with the introduction of PrEP in yellow, and you can see that PrEP has become the most commonly reported prevention strategy for casual sex. That occurred back in 2019 and has remained the case. There appears to be a bit of a blip in the 2021 related to COVID-19, where we had a slight increase in the proportion of participants reporting risk, which may be coincident with people returning to casual sex, but not necessarily getting back on PrEP or taking condoms with them and so on. But in the most recent years shown here, you can see that the proportion potentially at risk in red has dropped a bit. Now, another way we talk about this is by talking about prevention coverage. So that's the use of any safe method. So that could be having oral sex and not having anal sex, using condoms, having an undetectable viral load or PrEP. So from the dark blue up to the yellow, we classify as safe. And what's really pleasing about this long-term trend, despite a bit of variation in the COVID period, is you can see that prevention coverage overall during casual sex between men has increased significantly over time. Now, I will note that UNAIDS and others would like us to achieve 90% prevention coverage. So although we're nearly at 80 here, getting another kind of 10, 12% of coverage, as many of you will be aware, when you get closer to a target, it often gets harder. So while this is really pleasing, and we think this is coincident with new HIV diagnoses declining among gay and bisexual men across Australia, this increase in coverage, there is still quite a bit of work to do in engaging those people who aren't consistently protecting themselves or their partners. And I think that is my last slide. So no, I will mention the spotlights. So in the report this year, we also have some discussion pieces about contemporary issues. I've talked a bit about COVID-19. There is a spotlight section in the report on that, but I won't go into that here. I just want to note two other sections that we've included. One is on evolving trends in PrEP use, where we review research we've been involved in and collaborated with our partners, particularly at the Kirby Institute, on about how PrEP use is evolving in Australia. So the key things I just noted here was that our data suggests that PrEP use has continued to increase despite COVID-19, which is positive, but the way that PrEP is taken is changing. So we see more use of event-based dosing, which rather than daily dosing of PrEP. So this is taking pills around before and after sex rather than every single day. Research that that Tim and I and James, who's online, have been involved in, shows that there's strong interest in alternatives to daily dosing among gay and bisexual men in particular, strong interest in long-acting injections or longer lasting pills. So it'll be interesting to see how that evolves as things become available in Australia. And research that Anthony Smith and others has been involved in looking at the impacts of PrEP rollout on service delivery suggests that there's still some work to do in kind of skilling up people, particularly people who don't see a lot of people requesting PrEP, skilling up GPs to be confident discussing PrEP use with patients, and maintaining space for efficient models like nurse-led models of delivery. And we have some broader questions here as well about the effect of growing PrEP use and the use of undetectable viral load on negotiation between partners. And that's something that we've been exploring in qualitative research, but I think remains an interesting area, particularly given the recent disruptions by COVID, and then my other spotlight to mention, Mpox. So most of you will be aware that there was an international outbreak of an orthopox virus, formerly known as monkeypox, last year. It primarily affected gay and bisexual men and seemed to be driven by sexual transmission. Historically, it was thought that it was a close contact was the main transmission route, and that can still be the case. But this particular outbreak that emerged last year internationally, particularly in the Northern Hemisphere, outside historically endemic areas in some African countries, primarily seemed to affect gay and bisexual men who were sexually active with each other. There was a lot of concern associated with the outbreak because we didn't know how long it would last for and how many people it would affect. And the cases that were publicised involving rashes and skin lesions and fever and pain were quite difficult to witness when people could see what the virus did to them, even though it tended to be time limited. So my colleague, James McGibbon, who's online, and Anthony, who I mentioned, that James organised a national survey of gay and bisexual men that we ran last year. We had a very strong response from the community who wanted to tell us about their concerns about Mpox and their willingness to change behaviour. We found people were concerned about Mpox, but they largely had heard about the kinds of symptoms they should be looking out for. They indicated they were willing to at least temporarily change their behaviour to reduce risk, and they indicated a very strong interest in vaccination, which was then borne out by the speed with which people volunteered to get vaccinated. I'll note that internationally and in Australia, the outbreak has largely passed, but Anthony Smith, who I mentioned before, has also been following a group of people who were affected by Mpox and begun reporting on their experiences of diagnosis and being in close contact. So stay tuned for some more from that project in due course. And I will also just note for James and our benefit that the primary results paper on Mpox has just been accepted for publication, and it will be coming out soon in Sexual Health. So congrats to James and all our co-authors. Now I'm done. Tim, over to you. Oh, except I keep saying I'm going to be done, but then I'm not done. I'm going to move on to you now.
Thanks, Martin. So over the next few slides, I'm just going to be touching on the stigma section of the report. So primarily the data for this section has come from the Stigma Indicators Monitoring Project, which some of you may or may not be aware of. So just briefly, the project's been running since 2016. We've been collecting data, since 2016 from a range of different community groups, basically with the aim to monitor the experience, both the experience and the expression of stigma and discrimination, particularly that being targeted at people who are affected by bloodborne viruses and STIs. So to collect the data, we run and collaborate on a range of different national surveys. So those are either conducted in close partnership with community organisation partners, and at times also with other academic partners as well. both from within the centre, across the university, and other universities as well. So we're very grateful for the support, particularly of the community partners, in ensuring that we're able to collect the data from all of these different sources at any given time. So for each population group that we focus on, we typically collect data every 2 to 3 years. And so because we've been going since 2016, we're kind of now at the point where for each priority group, we have a couple of waves of data. So we're able to start seeing some of the trends that have been emerging over time. Obviously, when we're talking about stigma and discrimination, there's a range of different things that can feed into that. It can be a very complex issue to talk about. But for the purposes of monitoring, really what we're trying to do is collapse all of that down into a very straightforward measure. So the key questions that we use are listed there on the side of the screen. The main stigma indicator we talk about is that top one. In the last 12 months, have you experienced any stigma or discrimination in relation to your, and then depending on which group we're talking about, that it might be in relation to your HIV, if we're looking at people living with HIV, for example, or sexual orientation for men who have sex with men, injecting drug use for people who inject drugs, and so on. So really trying to capture what could be a very complex and broad range of experiences down into one particular number. We then have a follow-up question specifically around healthcare. So again, in relation to that particular reason people might be experiencing stigma, in relation to that, have health workers treated them negatively or differently to other people? Again, looking within that last 12-month timeframe. And that 12-month timeframe is really important to note because we do want to see how things are changing over time. So we're not talking about lifetime experience here, but really trying to get that real temporal aspect of it. To then look for an indicator of expressed stigma, we conduct surveys with the general public and with healthcare workers and use that bottom indicator on the right-hand side. Would you behave negatively towards other people because of their, and again, that list that I started using a few examples of before, and we'll see some detail as I go through the slides. But from that, we're talking about whether people would express stigma by reporting that they would behave negatively towards other people because of whatever reason that might be. Thank you. Perfect timing. So over the next few slides, I'm just going to go through the main survey data that we have included in this year's report. This is the first time we've really looked at the whole range of data across all the different priority groups since 2016. So starting off with men who have sex with men and looking at their experiences of stigma and discrimination in relation to their sexual orientation is how the item's worded. So you can see the broad stigma indicator in blue there's been a bit of a change over time from 2016, an increase up to 2018. And then since then, we've seen a gradual decrease reaching its lowest point in our most recent wave of data collection in 2021. So overall, the trend is that has been decreasing, but you can still see over 50% of participants reporting stigma or discrimination in the last 12 months because of their sexual orientation. So we tend to see this a bit with some of the other data as well, that, while, the inclination might be to say, oh, this is a good news, we're seeing a decrease. On the flip side of that, we are still seeing over half say that they've experienced stigma in the last 12 months. The other thing to note, looking at things, and I think men who have sex with men, this data is particularly useful to make this point. Some of the contextual things around when we collect the data can also have a significant impact on this. So, where you look at the highest point of stigma in 2018, where we've hit over 82% having experienced any stigma within the last 12 months. Within the 12 months prior to that, we had the marriage equality debate and postal survey. So, it seemed pretty clear that there were some implications of that sort of political environment being played out in this data set. And we'll see that across some of the others as well, but there could be any number of reasons why we see some of these variations and just some of those important contexts to keep in mind. We can also see there that negative treatment by healthcare workers in the red is quite a bit lower than the broader measure of stigma within this group. But again, still in our most recent wave of data collection, over a quarter of participants saying they've been negatively treated in a healthcare setting because of their sexuality. but that has remained relatively stable over the data collection period. We'll go on to the next one. Thanks, Martin. So looking then at people who inject drugs, again, if starting then looking at the negative treatment by health workers in red, that's been quite stable over time, but significantly higher proportions than what we saw on that previous slide. So around that 70% or slightly higher, reporting that they've been negatively treated in healthcare settings because of their injecting drug use. And then looking at the stigma indicator, slightly higher again. So the last couple of rounds, we see over 80% reporting any form of stigma and discrimination in the last 12 months because of their injecting drug use. One thing I will note, we can see a bit of a jump from 2016 to 2018, which is possibly due to some refining of our recruitment methods. We've been much more stable between the last couple of rounds, and we have recently completed another wave of data collection where we've worked very closely with member organisations from ABLE to collect a lot of surveys face-to-face. And through that, we've been able to generate much larger samples since 2018. So really, since we've been consistently collecting data in the same way, we're seeing very similar results. So from 2018 through to 2021, we'll be having some 2023 results available a bit later in the year, and really seeing some very similar things with very little change in terms of those experiences of stigma. Next one, thanks, Martin. People living with HIV, looking at the stigma indicator line, so any broad experience of stigma in the blue, you can see that there has been a decrease over time in these reports of stigma. And like we've seen with the others, the negative treatment by healthcare workers has been reported by a smaller proportion at each time point. And again, a little bit of a decrease over time from 2016 through to 2022. Although not, the trend line isn't quite as steep with that healthcare worker negative treatment compared to the broader stigma indicator. So again, while it's positive to see that we are seeing some decreases in people reporting stigma, we're still looking at over 1 in 3 reporting any experience in the last 12 months. So still quite a long way to go. And there's obviously a lot more nuance around that data. When we look at some of the qualitative projects that happen around the place, obviously stigma is still a very real thing for a lot of people living with HIV. So we want to be very cautious and not say, things are improving. But what we are seeing is that in this monitoring, the proportion reporting any experience within the last 12 months has been decreasing. And then we'd like to do further work to look at what some of those implications are. And that gets reported in other avenues beyond this report. Next one, thanks, Martin. Looking at people living with hepatitis C, this is one of those slides where we really see a lot of stability from 2016 through to 2021. Really no significant change in terms of past year experiences of stigma. It's been very stable at about half of the participants, people who have ever been diagnosed with hepatitis C, reporting any experience of stigma and discrimination. And what's even particularly interesting about that is the sample we use here are people who have ever been diagnosed with hepatitis C. So they may not currently have hepatitis C. Obviously, with the treatments available these days, people will go on treatment, clear the virus, and no longer be living with the virus. But even with having gone through that, we still see many of them reporting experiences of stigma and discrimination beyond the point of clearing the virus through treatment. And that's both in terms of the broad measure and also with the negative treatment from healthcare workers. So really interesting and I think very important to note that those implications and those the effects of stigma can extend far beyond just those points of people living with, but having also cleared hepatitis C. Next one, thanks, Martin. And then finally, I believe this is the last of the line graphs. It's been quite repetitive, so apologies for that. But we've recently started collecting data from sex workers as well. So while the others have been more long-standing surveys, we've implemented surveys with sex workers since 2020, having done 2 rounds of that so far. Between 2020 and 2022, you can see there very little change. And over 95% at both time points reporting any experience of stigma in relation to their sex work within the last 12 months. And in terms of the negative treatment from healthcare workers, 91.5% in 2020 has gone down to 88%. So when you run the trend analysis on that, that shows a statistically significant reduction. But you can see on the graph here visually, that's still a very, very high level of stigma and discrimination, both broadly and specifically within a healthcare context. So obviously this is a very real issue among the sex worker community. Go on to the next one. Thanks, Martin. So as I mentioned before, we also look at the expression of stigma and we collect data from the general public and healthcare workers for that. What I've got presented here on this slide is a breakdown from our most recent survey of the general public, which was, we ran that in late 2021. And I just wanted to show the breakdown of never, rarely, sometimes, often, always, which is how people respond to the item in the surveys. Rather than showing the trends over time, I think it's important to be able to highlight with the expression of stigma exactly what that looks like. So you can see across the different population groups, so we're asking people if they behave negatively towards, there's quite a bit of variation. So, and that's also in many ways reflective of what we've just seen from the experience of stigma. So people who inject drugs, when we see that there are close to 80% of the general public say that they would to some extent behave negatively towards people who inject drugs. That in many ways aligns with what we just saw in terms of the experience of people who inject. Interestingly, when you look at the many of the ones through the middle, so from HIV, hepatitis B, hepatitis C, even sex work and STIs, it's sort of around that 50% or somewhere in the middle who report any experiences or any expression of stigma or discrimination towards those groups. It's also important to look at when we're talking about not just any expression of stigma, but how frequently that would happen. So the way this is color coded, where you look at the orange and red, is what we tend to look at as the more frequent expressions of stigma, those who say that they would often or always behave negatively towards those groups. And for some of those, that's obviously quite a concern. Some of the numbers there are very high and really speaks to the need for broad level interventions and campaigns to be able to address public perceptions and the way people hold their attitudes towards some of these groups affected by bloodborne viruses and STIs, and particularly looking at how they behave towards those groups. So I'll just quickly note that we have collected data from the general public since 2017, a couple of different surveys. Some of the methods have been a little bit different. The samples have varied slightly, and accordingly, some of the reports of stigma towards each of these groups have fluctuated over time. Broadly speaking, what we're seeing is most of those have remained quite stable since 2017. If anything, we've seen some slight reductions in relation to injecting drug use, HIV and sex work, but those reductions really are quite small in magnitude. Again, it's one of those situations where the trend analysis shows that it's statistically significant, but in the real world, the percentage drop isn't particularly large. So there's obviously still a lot of work to do, and it's something that needs to be put on the public agenda to address these sorts of issues of stigma and discrimination. We'll just go on to the next one, Martin. So this is then looking at expressed stigma from healthcare workers. Again, asking the same question, would you behave negatively towards other people because of each of these different reasons? And you might notice that this slide tends to show a lot more blue than what we saw on the general public slide. So healthcare workers overall seem to be less likely to report they would behave negatively towards any one of these groups. Interestingly, when you look at our data, over time, we've shifted our sampling strategies. So initially, we were looking specifically at workers who were engaged in the bloodborne virus type field. And as you might expect, their responses were far more positive than what we've then seen with a broader healthcare workforce being sampled. So again, this is our most recent breakdown of our most recent data from 2022. And this is looking at a very broad healthcare workforce. So not specifically working in the bloodborne virus field, could be working in any aspect of healthcare. But again, I think it's just important to point out that some of those patterns that we saw from the general public are kind of held across into this slide. Things are shifted a little bit more to the right. We're seeing a higher percentage who are saying that they would never behave negatively towards these groups, but also the flip side of that is it's actually quite a concerning proportion who would say that they would behave negatively at all towards any one of these groups, particularly when we're talking about healthcare contexts. And you would expect that people, you know, the underlying ethos of healthcare, that people would be able to receive fair and equitable treatment regardless of their life circumstances and whatever condition they might be seeking healthcare for. Let's click over to the next slide. Thanks, Martin. So just one last thing I wanted to touch on that we highlighted in the report for this year is building on from the stigma indicators work to look specifically at interventions. You know, it's all well and good to be able to say, yes, stigma is a problem, and look, we can put a number on it to say how much of a problem it is. But what are we then able to do about it? So over the last couple of years, we've run a series of small intervention projects to see how we might be able to address some of these issues. Initially, we ran a small project based on contact theory with the general public back in 2020. We then followed that up with another project based on social norms theory in 2021. Both of those we've published the results on. The reports are on the website, and there are journal papers related to that as well. But what I just wanted to quickly focus on and what we touch on in the report is our most recent one, focusing on education and issues of structural stigma, a small project we conducted in 2022 around that. So the focus was on healthcare workers' attitudes and behaviours towards people who inject drugs and people living with hepatitis B. And we developed short video interventions that either provided some brief education to dispel some myths, if you like, around hepatitis B and around injecting drug use, and also looking at structural issues that might contribute to stigma existing in the healthcare system, and using different combinations of those content. So just to briefly summarise, because we're quite short on time and we want to leave some space for question and answers at the end, we found that both the educational and structural components of these interventions showed some immediate positive results straight after watching the videos. By the time we did follow up after a couple of months, it seemed that when there was a combination of both of these approaches, the likelihood of positive effects was stronger. So the combination seemed to improve the chances of positive effects lasting at least a couple of months. And that's kind of in line with what we saw from those other brief projects, that the immediate effect was quite strong and positive, but by a couple of months follow-up, things weren't necessarily as strong. So taking all of this together, plus the what we've seen in broader literature, there's real support for different approaches being able to have some kind of an impact in reducing stigmatizing attitudes and behaviors, but there's also that need for ongoing investment. Just doing one module, watching one video, having one professional development day isn't going to solve things. There needs to be recurring investment in that. We also found in this project that there was high support among the healthcare workers for structural initiatives and interventions to reduce stigma. So whether that's policies or procedures being put in place to support stigma reduction initiatives, there was really a lot of support, and people very much in favour of anything at that structural level to provide that broader context rather than just focusing on the individual and interpersonal aspects of reducing stigma within healthcare. And I think that might be about my last slide. No, I do have a summary. So yeah, to summarise, so basically what we're seeing over the last few years of this stigma monitoring work is that those experiences of stigma throughout every population group we survey still remain very prevalent. And even though we're seeing a little bit of change, a bit of variation in the trends over time, that prevalence is still something that indicates there's a lot of work to be done, particularly when we see the negative treatment within healthcare settings, even though that's reported at a slightly lower level than stigma overall. There's been little change over the last 5 to 7 years or so. So obviously still a lot of work to go there. Also looking at the the reported attitudes of the general public and healthcare workers. Broadly speaking, we've seen little change over time, again, highlighting the need that there really does need to be some intervention work and large investment in that. And as I was just mentioning, our intervention research has shown that different approaches have been effective in varying degrees. So there's some benefit in all of those different approaches that we've looked at and that other people have looked at in the published literature as well. So that really highlights the need to look at implementing multiple approaches and move beyond a focus on specific stigmatized identities. So rather than looking at stigma towards HIV specifically, looking at stigma as a broader issue, and that can be directed to any number of different identities, behaviours, or conditions. Looking at approaches that encompass all of that is something that we think is particularly important and are continuing some work on over the next couple of years. And I believe that is my last slide.
Thanks, Tim. Okay, so we've done pretty well on time. We've got just under a quarter of an hour left. I'm going to stop sharing. Thanks to those our colleagues who've been monitoring the chat as we went. I believe I'm just checking to see if we have any unanswered questions. Tim or Carla, do you want to just clarify the very last question? Yeah. Oh, the second last question is all the stigma data on gay and bisexual men. If so, have any separate data been collected on women?
There we go. Carla has just responded to that one. So
yeah, so I'm just clarifying, women, all people are included in the general public sample, people of all genders and backgrounds in the healthcare worker sample, and then the different population groups. So people living with hepatitis C are not just men, like men, women, and non-binary people living with hepatitis C. So it was only the gay and bisexual men group, the MSM group, which is just men, I imagine.
Yeah, that's correct.
Great. Any questions or comments from people? If you would like, if you're feeling brave and you want to shout out or ask a question. Tim, I actually thought of, well, oh, and Karen's raised her hand, but I'm going to ask my question now, so that means we've got two. Looking at it's good seeing the stigma data because I'm not involved in that project. The hepatitis C one experience stigma is really odd. It stands out that people with an experience who've either got hepatitis C or they've had it in the past say that they're more likely to have been treated negatively in a healthcare setting than general. Is there any commentary in the team about why that might be the case? That one really stood out to me, that those lines flip over.
Yeah, it's actually not something we've really talked about in a whole lot of detail. It's really only been since pulling this report together that it's been quite so obvious. One thing to note on that is that there's a lot of overlap, particularly in our last couple of waves of data collection. The people living with hepatitis C or who have ever lived with hepatitis C are a subset of our people who inject drugs survey. So I think the issue of different layers of stigma and intersectionality is a huge one around that. We do frame the questions around hepatitis C, kind of as its own separate module within the survey to say, at this point, we're asking about Hep C. Other parts of the survey, we ask those questions specifically around injecting drug use, so that there is that disparity, and you can see when you put those side by side that people aren't answering exactly the same on both of them. But I think that probably does play into it to some extent. The fact that even though you ask questions specifically around hepatitis C, you can't disentangle someone's stigmatizing experience from everything else that they've experienced. So that's kind of one working theory, I suppose. But yeah, certainly something I agree is worth looking at in a bit more detail, because it is that slight anomaly where, the lines flip over. Although, not by a huge gap, but certainly a slightly different pattern to what we see elsewhere.
Thanks, Tim. Now, Karen, Did you still have a question? Otherwise, I'm going to move to...
No, Anthony answered my question pretty succinctly, which responds
Great,
to...
thank you. Vijay, would you like to ask yours? Thank you.
Oh, I think someone else was there before. I want to be respectful. I don't know the
Oh,
name.
well, you
E. Williams.
E. Williams, right. We'll go to E. Williams first.
Yeah.
Thank you.
You're an absolute gentleman. Look, it's just a very quick question. And I guess the answer will be no. Was there any data collected from prisoners?
Short answer, no. But yeah, look, in broader conversations, it has been acknowledged that, yeah, that is something, that would be worth looking into. But yeah, at this stage, no, unfortunately. Short answer.
Just to let you know, we'd be more than happy to help with that in South Australia. We have been providing support to prisoners for 11 years now in South Australian prisons. So yeah, it would be interesting to be involved in that.
Always happy to have conversations about how we can expand the work. So let's get in touch.
Awesome. Thanks.
Thank you. And Vijay, do you still have your
Yes,
question?
I do. Thanks, Martin. And Tim, the question is for you. So the question on stigma was, it's more of an attitudinal question. How would you behave? Okay, rather the actual behavior, any data or any commentary on that. Have you behaved in a way when you came across such and such population? Any comment on that?
Very good point. And yeah, certainly something that we have grappled with, particularly with some of the intervention work we're doing, where really seeing a shift in attitudes is one thing, and we assume there's going to be a correlation with behavior, but obviously it's difficult to actually measure behavior. And particularly, when we're doing follow-up after a couple of months and, say in the last 12 months, have you behaved negatively? Then there's a little bit of an overlap, or, have you even encountered someone since you did the baseline survey that we'd be able to make comparison? In some of the earlier, back like the 2016 waves of data collection, we did have some questions about, have you behaved negatively? And I think one of the difficulties we had there was also, if people said never, you then also need to include a whole range of questions about, well, did you encounter someone? Did you work with someone? So it kind of made things a little bit more complicated. In the interest of being able to provide that broad monitoring number, that's why we focused on the, I suppose, what we often refer to as behavioural intention. Would you behave negatively? So yeah, totally agree that it's not the ideal measure of actual behaviour, but it's kind of the best proxy we've got at this stage, particularly looking at the context and being able to apply to a broad range of people who may not have contact with the groups we're talking about, or even if they do, may not realise that they do. So that's kind of the thinking behind it.
Thank you, Tim.
Thank you. So there's a question from Simeon. Are there studies related to how structural stigma such as migration has impacted the well-being or mental health of migrant people living with HIV? I'm going to take that as a team question here. Any comments, thoughts, Tim? I know, Simeon, there's a lot of focus at the moment on migrants and particularly people living with HIV. That particular, there are some, I wish my PhD student, Simeon, was here. She would be able to answer this question, I think. Thoughts, Tim?
I was thinking exactly the same thing. Where's Simeon when you need her?
When we need her, we might need to take that one on notice.
Yeah.
We have another question. I think I'm going to ponder there in case I'm missing something really obvious to reply. But my first answer is perhaps not specifically on that intersectional one. I will acknowledge Simeon is actually very interested in the experience of migrants living with HIV and how that affects their engagement in care and their general well-being. Miradula, is that the right way to pronounce your name?
Yes. Thanks, Martin. Tim, thanks for that really fabulous presentation. I wanted to ask if you could speak a little bit more about the structural aspects of the intervention that you briefly discussed, and whether the team had any thoughts, or if you've begun doing any work trying to understand how structural stigma can be measured in surveys, and kind of what components, what might we consider? Because I think there's quite a bit of data on interpersonal stigma, but more and more we're realizing that we need to go beyond that. So just your thoughts on kind of what the work you've done and kind of where you see that piece moving forward. Thank you.
Yeah, thanks. Great question. And yeah, I think you're absolutely right that particularly in survey work, the interpersonal stuff is so much easier to measure. You know, you're asking someone about their own opinions. So that's, you know, that tends to be the default. For the project that I briefly referred to, in the video intervention that we put together, we basically, it was basically putting forward a proposal of an inclusion charter. So a structural piece of document that would apply across a healthcare setting, that would, rather than so much focus on the reduction of stigma, the promotion of inclusion. So everyone is included, everyone is treated equally. So trying to put that positive spin rather than, you know, hammering in on the negative. Because part of that being some of the feedback we receive, particularly from healthcare workers when we present this kind of data, is, you know, everyone agrees how important it is, but when you focus so much on the negative, often it can be hard to get the buy-in. So we flipped it around and tried to talk about this inclusion charter and what people thought of it, whether they thought it would make a difference, et cetera, et cetera. And yeah, so interestingly, as well as people saying, oh yeah, that all sounds like a wonderful idea, some of the groups who were exposed to that within the intervention showed slightly different responses, or, you know, stronger shifts in some of their personal attitudes and behavioural intentions and so on than what we saw from the group who didn't have that included in their video. So that was kind of the perspective we were coming from there. In the 2 minutes we have left, I'll just mention that we do have some bigger projects around stigma that have kicked off recently. So we've got a large project looking at what we've currently termed a universal precautions approach to stigma reduction. And so there's an element within that where, you know, we're trying to understand more of the structural things and how that can be addressed. And some other projects, Eleanor, who I think is online, is leading a project. Oh, there she is, she's popped up. Is leading some work around looking specifically at structural issues in healthcare settings. In terms of how we implement that into surveys, I think that's still quite a way off how we get to there. So at the moment, the focus has been more on the qualitative side of things. We're certainly starting to look at it in a lot more detail because, as you say, it's now, yeah, shifting towards that way that we need to understand that a little bit more. Eleanor, did you want to chime in briefly?
Yeah. So there's a qualitative piece of work that we're doing at the moment, canvassing perspectives from key stakeholders about what organisational or structural stigma looks like in healthcare. What are the potential strategies that we could use to address it? And we've also got some questions on there around measures or indicators that could tell us if we've been successful in changing it. And then, as Tim mentioned, in that larger project in designing and implementing interventions in healthcare, we've got a real focus on how can we include a structural or organisational element. So whether that's looking at quality improvement projects, to how we could change specific policies. So definitely watch this space. That's something that we're moving into, looking at structural stigma. Thanks, Tim.
Thanks very much.
Eleanor. Now, I'm conscious that we're now dead on time. It's been a packed hour. Thank you all for your engagement and your attention and your questions. If you'd like to follow up with Tim or me or any of the people who've been mentioned, please reach out to us at CSRH. You can see that we love getting questions and suggestions for things to follow up. And we look forward to seeing you at future CSRH online seminars. It's a great way to connect with many of you. I will also note that when the report is finally available with its plenitude of topics and areas, we will send a copy to everybody who registered for these seminars as well. And I wish you all the best with the remainder of your afternoons. Thank you for joining us.